Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Thank you, Ugo. So welcome everyone. I appreciate you being here. And the topic of today is treatment planning considerations in full arch implant rehabilitation. So, 35 webinars already. I mean, absolutely amazing global collaboration and sharing of knowledge. So I decided it would be appropriate that we talk about now patients who may need a little bit more than just the single tooth. We're going to talk about the full arch implant rehabilitation today. And truly honored to be able to speak to you guys. So I appreciate you coming, and I hope it's an educational experience. So I have nothing to disclose. I have no financial relationships with any of the products that I'm going to talk about today. So I just want to give a brief introduction to my background. So I am from Chicago, Illinois. I actually went to dental school with Dr. Onarobe, and I really just want to take a moment and acknowledge what we are doing here. In the spirit of global education and collaboration, improving healthcare, empowering the community, this education series has really happened thanks to Dr. Ugo Onarobe. And as a UIC alumni, I'm very proud and thankful for Dr. Uvo for everything he has done. And I just want to say that Dr. Uvo has a personality, it's just larger than life. He has so much compassion, and whenever there's a crisis, he's the first one there. And not only does he volunteer his own time, but he actually recruits others to join the cause. So I'm very proud of Dr. Onarobe for everything he has done, and I'm truly thankful for representing the whole dental community on a global front. And of course, just thank you, Dr. Ugo, for everything you're doing for humanity. So this lecture is it's about the fundamentals. Okay, so we're going to talk today about full arch implant rehabilitation, a little bit about the background. Who is this type of treatment for? You will hear, in the literature and in many other lectures, there is lots and lots of different kinds of terminology. So we're going to flush that out and kind of, take away exactly what type of terminology we should be utilizing when describing these types of prostheses. Very important concept is we're going to go through some diagnostic classifications, as you saw in some of those pre-questions. We're going to do a little bit review about biomechanics, and then we're going to talk about a couple of patients and their cases and how we go about the workflow for treatment planning these complex patients. So, as I mentioned, I'm from Chicago, so no lecture would be complete from someone from Chicago without a quote from Michael Jordan. So, if you're not familiar, Michael Jordan was a famous basketball player when I was growing up on the Chicago Bulls. I actually live just down the street from the United Center where the Chicago Bulls play. And essentially, we're here to talk about the fundamentals. So Dr. Michael Jordan says, get the fundamentals down and everything else you do will rise. Okay, so just as a building, right, we need to have a strong foundational support, strong foundational knowledge before we can start building upon that. So today is really about the fundamentals, and I tried to cater this to be for everyone. So if you already know some of this information, it's a good review. If you haven't seen this before, it'll be an excellent learning experience for you. So we talk about fundamentals, and we talk about this concept of reverse engineering. So what we're doing in full arch implant rehabilitation is actually reverse engineering. Okay, so on the right side, you see a picture of the city of Shanghai. So on the top, that was actually what Shanghai looked like in 1990, okay? And below you see what Shanghai has blossomed into in 2010. So that's a 20-year difference. And the reason of why they were able to accommodate this efficiently and effectively is all from planning. Okay, city planning, blueprints, committees, all sorts of planning, and just laying down the foundational work before building up. And that's really going to be the theme of today. So full arch reconstruction. Why do we care about full arch reconstruction, right? So is edentulous common? Aren't people hanging on to their teeth longer and longer with longer life expectancies? Can this type of procedure be performed on partially edentulous, or do they have to be completely edentulous? What are the different types of prostheses available? Is it just like putting crowns on teeth, or is it a little bit different? And of course, what are the surgical implications? So really, we want to be able to ask ourselves these types of questions. Okay, so actually, edentulous is quite common, and it's estimated, we know from Dr. Turklinaz, that the number of patients in need of 1 or 2 complete dentures in 2020 is actually 37 million. Okay, this is a statistic from the United States. Now, essentially, there is an overall increasing number of adults. Okay, now essentially that's 1 in 10 people in the United States. So this is not for a select, tiny group of patients. It's actually a fairly common issue that I believe it's important for dental providers to be able to be familiar with. Why does it matter? Well, it is shown that we know from Dr. O that having a fixed implant prosthesis does lead to a higher quality of life. And this is comparing to those that have removable complete dentures. Okay, and we've all seen the patient who has a set of complete dentures, maybe for many years, where they just simply can't get used to them, or they're not able to function properly, and they may end up living their lives like this for several years. So being able to offer another option is highly valuable in my opinion. So we have a few different categories of what type of patients is this treatment for, right? So we have 2 main categories, and we have the completely edentulous patient, as we know from our complete denture principles, with some atrophy that may be seen. And these are patients that have typically have lost their teeth or in the process of losing their teeth, and they may not have had teeth for many years. And in those cases, we have severe atrophy of the alveolar ridge, and we're going to talk about that and how to classify that. The other category of patients that we are talking about are patients that do have teeth, however, they are in a terminal state. So we call this the terminally dentate state. And it's a fine line where the restorative provider has to make a decision. Should I deconstruct and restore all of these teeth with fixed prosthesis? Or do I make the decision to remove the teeth and actually start from scratch with a full arch fixed prosthesis? So the 2 main categories are fully edentulous and terminally dentate. Okay. So in terms of the terminology, you may hear this, in lectures, in literature, even on TV. There's all these different names for the same thing, essentially. So we hear, all on X, all on for hybrid denture, hybrid prosthesis, implant supported fixed prosthesis, or a fixed implant complete denture. And of course, all the implant companies have their own versions of what they call it for the full arch prosthesis. So how do we know that we're talking about the same thing? Well, let's look at that term hybrid prosthesis. So the glossary of prosthodontic terms defines a hybrid prosthesis actually as a non-specific term. And it's essentially any prosthesis that does not follow a conventional design. So when you hear the term hybrid prosthesis, it's really an umbrella term. And what the colloquial term for is a hybrid denture, right? But in my opinion, I think that we should be a little bit more specific. So I like to use the glossary of prosthodontic terms because, in my opinion, that is the authority on all of the different types of prosthesis. Especially from a surgical background, it's important for me to understand these definitions. So we look at the glossary of prosthodontic terms, and there are lots of different definitions. We have implant-supported crown, implant-supported denture, implant-supported prosthesis, and you can certainly look this up and go into details to clarify this, but we are going to focus on the term that I believe is the correct term for what we're describing, is a fixed complete denture, okay? Now, a fixed complete denture is defined as a fixed dental prosthesis that replaces the entire dentition and associated structures of the maxillary mandible. It cannot be removed by the patient, and you can add these descriptive modifiers or terminology as adjectives to each one. For example, a fixed implant complete denture, or an FICD, is my preferred terminology and is the preferred terminology of many of the prosthodontists that I work with. But I do believe in having a uniform and consistent way of describing these terms with your referring doctors, with any surgeons you're working with, and even with your patients, just to be on the same page. So the next question is, where do we start? You know, we see here there's 3 steps, from the edentulous patient to implant surgery to restoration. It looks fairly simple, right? But we know that to do this predictably, we need to have a systematic set of steps to be able to achieve the results we want to do. How many implants do we place? What is the final prosthesis going to be? You know, what material will it be made out of? Will it be immediately loaded, or is it going to be delayed? Will the transition line be hidden whenever the patient smiles, right? So these are all considerations that we need to be thinking about from the first day, from the first exam. And from a surgical perspective, it is equally important for me to be considering all of these different prosthodontic and prosthetic principles so that I can, again, reverse engineer and work backwards to be able to start. So I love the Stephen Covey quote, begin with the end in mind. Just like the development in Shanghai, we need to be able to envision where it is we want to go to then be able to decide how do we get there. And I borrow this same application to software development, right? So, you know, we have, I'm sure, a lot of young people on the webinar who are using these applications right here, right now, right? We're on Facebook live streaming. We've been talking about this lecture on Instagram. So these applications, what you see as the end user is only just the tip of the iceberg, okay? There's lots and lots and lots of back-end development that eventually leads to the functional app. And you can use the same analogy when we're talking about treatment planning for the fixed prosthesis. So when your patient comes in, they may say, I saw this commercial on TV. I want that. I want that fixed, beautiful prosthesis that when the patient smiles, it looks beautiful. But they currently may be in a complete edentulous state or a terminally dentate state, and they don't understand all of the back-end development that comes into place. So they're viewing the tip of the iceberg as their desire, and it's our responsibility to educate these patients on the various steps, right? So we can't just simply jump from the beginning to the end. We have to do our appropriate back-end development, just like an app, to be able to get there. So really, it comes down to appropriate treatment planning. The more effort and time you can put in to appropriate treatment planning, then the more predictable your outcomes are going to be. So my mantra, and in my training, this was always instilled in me, is know your diagnosis, okay? And when I was in school, when I was in residency, I would look at a case and I would immediately think, I'm going to do this. I'm going to place 4 implants. I'm going to place 5 implants. This is going to be a zirconia prosthesis. And I would skip the in-between steps of actually going through the diagnosis and knowing what type of diagnostic criteria the patient has. And this is something that I've learned to apply to every patient and every full arch case that I do. So we will review today these 3 specific diagnostic criteria, the K-Hood and Howell classification, the Mish prosthesis classification, and we're going to go through the Bedrosian zones of bone. And in my opinion, these 3 are absolute foundational to treatment planning in full arch implant rehabilitation. So we look at the K-Hood and Howell paper, okay? And this is an absolutely classic paper, all back from 1988, okay? And K-Hood and Howell published this paper that classified essentially a resorption pattern of the alveolar bone, okay? And what they did is they took 300 dried skulls and they analyzed them on how the bone resorbed. And what they found was that the basilar process of the mandible actually stayed relatively stable, whereas the shape of the alveolar process, meaning the bony housing around the teeth, is where you have significant vertical and horizontal resorption. And basically they found that the maxilla and the mandible do follow a predictable resorption pattern. It's not completely random. And the bone resorbs both vertically and horizontally from the buccal. Okay, so we've seen those pictures of edentulous patients where they have very collapsed soft tissue, collapsed amount of vertical dimension. And when we talk about restoring these patients with prostheses, we need to restore these patients with the prostheses, okay? And I like to make this comparison from the background of a surgical perspective that the same principles of corrective jaw surgery and orthognathic surgery apply to full arch implant rehabilitation. What does that mean? That means that we're looking at the position of where the teeth need to be in relation to the lip, because that determines where we're going to place the maxilla in a Lefort type of procedure. And it's absolutely the same principles as complete denture principles, right? When you're making a denture, you want to know where is that tip of the incisor going to lay? Where is the position going to be? How is it going to support the lip? What's it going to look like when they're smiling? So given the amount of resorption the patient has is going to determine where you are going to place that final position of the incisor, okay? And the Kaywood and Howell classification is one that's going to help you determine how severe the resorption is. Now, we know that the bone is resorbing, right? So how do we know that the bone resorbs? Why does it resorb? Well, we know that bone is very dynamic, and it can grow, it can increase in density, it can resorb, or it can disappear. We know this thanks to Dr. Julius Wolf, who was actually one of the pioneers in orthopedic surgery principles. Now, Dr. Julius Wolf was a German surgeon in the 1800s, and he was actually the first founder and director of the first orthopedic surgery department in Berlin, in Germany. And it was him, actually, who was the first one to describe this relationship between bone geometry and mechanical influences on bone. And this whole concept is what we now know today as Wolff's Law. And the Britannica Encyclopedia defines Wolff's Law as every change in function of the bone is followed by a certain and definite changes in its internal architecture and its external conformation. So what does this mean? This means that if the bone is stimulated with a force, the body maintains the bone. In other words, this is actually one of the factors that is thought to cause osteoporosis, meaning use it or lose it. This is actually why, to this day, the American College of Sports Medicine recommends weight-bearing activities and endurance activities for those that involve the joints, like jumping, tennis, jogging, to help prevent osteoporosis. So when there are no teeth in the alveolus, we're going to have a similar bony resorption, the whole use it or lose it pattern. But wait a minute, we know from Kaywood and Cowhood that the basilar bone is still there. Why doesn't all of the bone resorb, right? Well, there's a whole lot more going on in the maxillofacial and oral cavities than just the teeth, right? We have muscles. We have lots and lots of muscle attachments that are continuously stimulating that basilar bone. Even if the patient is edentulous, they're still masticating. They're still utilizing their muscles of mastication. They're utilizing their muscles of facial expression on a daily basis, and they're also utilizing their muscles of speech and swallow. So these muscles actually do apply forces to the bone that prevents the basilar bone from resorbing, okay? And that's why we see this pattern of absent alveolar bone in completely edentulous patients, but still presence of basilar bone. And this concept is important to understand because as we understand the way that bone resorbs, we can help treatment plan the way to restore that bone with a prosthesis. Now, I absolutely love this demonstration, okay, of a patient who, for example, is only missing teeth for a short time versus a patient with severe atrophy who has been missing teeth for a much, much longer time. And this is the example of why we have to know how much bone is resorbed in order to appropriately restore these patients. So if you look at the picture, we see that in the picture with very minimal bone resorption, example on the left, we're actually going to use a different prosthesis to restore this patient, whereas opposed to the picture on the right, much more severe atrophy, the patient has been missing teeth for a much longer time. We know that we're going to use a different prosthesis, okay? And we're going to talk a little bit about that moving forward. Now, the next classification I want to discuss is really this prosthodontic classification by Dr. Mish, okay? And essentially, it's broken down into a fixed prosthesis, removable prosthesis. However, it's determined by how much of the tooth, the bone, and the gums you are restoring. So for the purposes of today, we're just going to focus on what we call an FP1 and an FP3. Now, just to keep it simple, we're just going to call the FP1 prosthesis, it replaces teeth only, okay? Versus the FP3 prosthesis, it replaces teeth, bone, and gums, just like that picture that we looked at. So when we look at things in a parallel situation, we can see the level of the bone is going to dictate the final prosthesis. So in the FP1 situation, we have very minimal bone resorption. It's basically level of bone that you would have in a dentate patient. However, in FP3, we have some more severe resorption, and we see that the prosthesis is replacing teeth in addition to the bone and gums, and that's typically done with pink porcelain or acrylic or zirconia, okay? So another example of how your diagnosis is going to affect your prosthesis. So we see that the more severe resorption we have, the more amount of prosthetic material we are going to need. So thinking the end in mind, by knowing what our final prosthesis is going to be, we'll then determine what type of implants we're going to place, how we are going to place them, how we are going to treat and plan the entire process. Now, another illustration of the difference in what would be considered a teeth-only defect versus a teeth, bone, and gums. And that amount there in the vertical red line is demonstrating the amount of alveolar bone that has resorbed. And that amount of alveolar bone that has resorbed is not going to be reconstructed surgically. It certainly can be, and it has been done with Lefort osteotomy and horseshoe grafts, which are not typically performed anymore, but rather with a FP3 prosthesis. Okay, and this is just an example of what we are looking at, FP1 versus FP3. Now, what about the bone? Okay, once we know which type of prosthesis we want to apply, the next step in the working backwards workflow is looking at the bone. Okay, and we know that as patients age and undergo atrophy, there is a certain degree of maxillary sinus pneumatization that occurs, right? And we all know that we need enough real estate, we need enough stability in the bone to be able to load any type of implants. So we look at this patient and we see this severe pneumatization of the bone. One option is bone grafting, right? We can certainly perform bilateral sinus lifts, perhaps some ridge augmentation in the anterior maxilla, so that we can place 6 axially oriented implants. That means implants that are straight up and down, and we can go ahead and create our prosthesis. However, there is the tilted implant concept, and the idea behind the tilted implant concept is that we can actually avoid bone grafting in the appropriate scenario and actually place tilted implants. And this is the idea that we look at when we are missing so much bone that we cannot place axially placed implants. Okay, and what does this do? Well, it does several things. It maximizes our anterior posterior spread for our prosthesis. It allows longer implants to be placed, which means more surface area for osseointegration. It also opens up the option to restore a full arch in patients who have had severe resorption without any bone grafting. And we can actually obtain for a smaller occlusion with a slight cantilever, which is a lever arm, and we're going to talk about that shortly. So in this option with the tilted implant concept, we can actually offer the patient a graftless type of procedure. What that means is we can save the patient a significant amount of time for the grafting. We save the patient additional morbidity and surgery and exposure to anesthesia. And most importantly, we also just save the patient overall cost and experience of having to go through that. So in the tilted implant concept, we see here that we angle our implants to avoid our vital structures. So in the maxilla, that's going to be our maxillary sinus. In the mandible, it's going to be the mental nerve foramen. So when we talk about tilting these implants, we have to understand at least a basic understanding of implant biomechanics. Okay, so there are some classic studies in the literature that are very very important, and I recommend you take a look at some of these. It's not necessarily the most exciting to look at, but it is a foundation of implant biomechanics. And we look at the Journal of Prosthodontic, the Glossary of Prosthodontic Terms, which defines biomechanics. And my favorite is the third one here: an application of the principles of engineering design, but as implemented in a living organism. So what we look at is we see the classic studies here, that we know from the classic studies that the optimal forces on an implant are along its long axis, okay, meaning straight occlusally loaded implants. But what if we want to obtain implants further back in this picture on the right? What if we want to obtain first molar occlusion, but we only have enough bone to place it in the first premolar? Well, we know from this literature that the longer the lever arm is going to be, the greater the amount of tension force that the implant is going to experience, right? And that can manifest in a variety of ways. That can lead to prosthetic failure, prosthetic fracture, screw loosening, screw fracture, can lead to peri-implantitis and bone loss on the distal surface of the implant, can even lead to implant fracture. So we know from this literature that we want to reduce the distance of our lever arm and reduce the amount of cantilever. One way we can do that is by angling the implant. Okay, either we angle the implant to reduce the cantilever, or we simply don't make a prosthesis that goes back that far. Well, we would like to offer the patient first molar occlusion if we can. So the idea of tilting the implant makes sense, right? So we can see that if we reduce the amount of the cantilever in the lever arm, we can actually reduce the amount of tension that implant is going to be on. Now, what I like to look at is we're talking about, do we place axial implants? Do we place tilted implants? We have to look at the bone anatomy. And my favorite classification was described by Dr. Bedrosian as these three bone zones. Okay, and this is a very nice way of looking at a Panorex and just kind of getting a general idea of where you're going. And granted, this is not a classification that looks at the 3D dimension. It's just a kind of a screening tool to help you ascertain what type of category you're going to place these patients in. Now, zone 1 is defined as the premaxilla, meaning the anterior maxillary teeth. Zone 2 is in the premolars, in the anterior aspect of the maxillary sinus. And zone 3 is in the molar region. Okay, so determining what zones your patient has bone and does not have bone in can help you determine what type of configuration, what type of geometry you're going to place these implants in. And there's a very nice algorithm from Dr. Bedrosian that describes this, meaning if you have adequate bone, meaning vertical and horizontal width, in all three zones of bone, you can place traditional axially loaded implants, straight up and down, right? You can also convert a patient who does not have enough bone with bone grafting to then place traditionally axially loaded implants and recreating presence of bone in zones 1, 2, and 3. If the patient is not interested in bone grafting, or you don't think that that would be a predictable outcome, and the patient has bones in zone 1 and 2, but no bone in the molars by zone 3, you can place 4 traditional implants, however, tilting those 2 back implants like we saw in the previous scenario. What if you only have bone in zones 1? Right? You only have enough bone in that premaxilla area. You have severe pneumatization of the sinuses. There's a very limited arch length. Well, then we consider zygomatic implants. Okay? And zygomatic implants are longer implants that traverse through the entire maxilla and engage into the zygomatic bone, right? And they can present as posterior stops for our posterior implants. And lastly, if we have a severely atrophic maxilla, insufficient bone in all three zones, in that case, we can possibly consider 4 zygomatic implants. Now, this is not a lecture about digital technology. I am a strong proponent of utilizing digital applications to help us along our way in treatment planning. But we take a look and we see, if we have a 3D slice of an area of terminally dentate or edentulous spaces, where do the implants need to go, right? We looked at the general panorex in terms of determining where the vertical height of the bone is, but we also need to look at the horizontal aspect of the bone. Now, where you are going to place this implant from an inclination standpoint, it's not simply where you think the bone is, right? It's not simply where you think the restoration is going to go. We need to be thinking from a crown down approach, or what's known as a prosthetically driven approach. So what we like to do is incorporate a mock-up or some type of draft of what the final prosthesis is going to look like and reverse engineering the position of that implant to that position. So we can see, comparing the pictures from the left and the right, on the left, basically placing the implant in the middle of the alveolus and where we think the crown could possibly be. But when we do overlay a diagnostic wax-up with appropriate occlusion and appropriate dimensions for that tooth, we see that we need to tilt that implant slightly more buccal to get that screw access hole coming out of the occlusal plane. So digital technology can certainly help you along the way, although of course we can do these workup steps completely analog. Now, having gone through your diagnosis, having known what your final prosthesis is going to be, understanding the zones of the bone and where you're going to place the implants, we need to put this all together. And for every patient, it's important to have a consistent and systematic diagnostic workflow in terms of how are you going to determine what type of prosthesis. Now, these 2 papers listed here are personally have been a great learning experience for me in my training about creating this type of workflow, and I highly recommend you just take a screenshot or take a look at these 2 articles as creating a systematic way. But what it does is it puts together a system of steps to be able to analyze how you're going to do this. And what I like to do is adapting some of those analog techniques with digital technology. And in first step is involving a duplicate denture. So if you have a patient who is edentulous, you duplicate their denture and you create it essentially with some acrylic, where you can now see through where is the difference between the level of the teeth and the level of the patient's natural alveolus. And that gives you an idea of, is there or is there not a composite defect, meaning a defect that is more than just teeth only, a defect that is teeth, bone, and gums. That will then determine what type of final prosthesis you're going to have. Personally, I like to do this digitally, whether with a digital wax-up or doing a dual scan technique with a denture, so we can determine where the teeth need to be, and that's done by merging your planned restoration with the patient's diagnostic situation in the CBCT. And from the bottom right picture, you can then work backwards and plan your implant positions to where those teeth are going to be. Now, in terms of creating a digital workflow, that's really a separate lecture, and we can certainly talk about that more in the future. But the very basics here are getting to know your final prosthesis. What is your final prosthesis going to be? Merging that final prosthesis with the patient's existing condition in the CBCT, and then planning your implant positions within the patient's existing alveolus, but directed to be appropriate for the final prosthesis. So let's take a look at this in action. So we have here a patient who has a heavily restored dentition. It's been restored to this existing occlusal plane, which has created lots of problems for this patient. Extensive discussions were had with this patient and their restorative provider as to whether or not to perform an extensive deconstruction and reconstruction with fixed restorations, or whether or not to simply extract the teeth and start from scratch with a full arch fixed hybrid prosthesis. And that's what was done in this case. So we take a look at the x-rays, heavily restored dentition. However, she has a lot of her teeth, and it's a difficult decision, and it's important for us as providers to educate these patients to what their options are. And in this situation, the patient chose for a full arch implant rehabilitation. So what was done in this situation is that type of hybrid analog digital technique where we take a digital wax up that can be based off of the patient's existing dentition, and we merge that with the patient's CBCT. So from a digital wax up, we can then overlay implants within the patient's natural bone in the ideal positions that we would like them to be. What that looks like is here, and the way I do this is I plan the implants. I then make two measurements. I make a measurement from the platform of the implant to the incisal edge of the planned restoration. That allows me to know that I have enough restorative space to accommodate that prosthesis. Because if we do not have enough restorative space, we're continually going to be having prosthetic complications, prosthetic fracture, broken screws, occlusal issues, peri-implantitis. These are things that we can help avoid from the beginning. The second measurement I make is from the platform of the implant to the height of the alveolus. And I write that down for each implant that we place so we can perform a very precise alveoloplasty and alveolectomy where we don't remove too much bone, but we remove enough that we'll be able to accommodate our prosthetic materials. And this is what that looks like, where we are able to perform dental extractions, we remove the disease, we perform our alveoloplasty, in this case for prosthetic purposes, we plan our implants, and we immediately load the prosthesis. And with this type of workflow, we can predictably attain this transformative treatment. And we have a very happy patient, and this patient actually was able to get their prosthesis without any bone grafting and was saving a significant amount of time. So this truly transformative work is one of the reasons why I truly enjoy performing this type of procedure. However, knowing the diagnosis, having a consistent workflow are absolutely prerequisites in my opinion. So what about more complicated cases? Can this be done for patients who perhaps already have some implants, maybe they still have some teeth? In this situation, we have a patient who has what would be considered an FP2 classified prosthesis, meaning it is a teeth-only prosthesis, but the teeth are slightly elongated. And that was done because the patient had a low smile line, and we're going to talk about that a little bit later in the lecture. However, this patient had failing implants in the anterior and non-restorable remaining teeth. So with the patient's restorative provider, it was discussed that a full arch implant prosthesis was to be completed. So we do our workup. We know what our final prosthesis is going to be. That's determined from a combination of a digital hybrid analog workup. We look at the patient's existing panorex. We see, I'm sorry I don't have the CBCT slices, but we have a very, very atrophic residual ridge, meaning not enough room, not enough bone to place implants without significant bone grafting. We also see she does have a failing severe peri-implantitis on the lower left. So what we do, we go back to our systemic workflow. We determine whether or not there is presence of a composite defect. So we can see here from the positions of the teeth, okay, we don't even need to make a duplicate denture. We can see with her existing prosthesis that there is a composite defect. This means that our final prosthesis will be an FP3, meaning replacing teeth, bone, and gums. So we do this digitally, okay, and in patients who have that absence of zones 1, 2, and 3, we fall into that category of needing 4 zygomatic implants. Well, now we're talking about zygomatic implants, so how can we place zygomatic implants in a restoratively favorable position? Well, myself and Dr. Malora looked at this question, and we actually developed a routine called the Restoratively Aimed Zygomatic Implant Routine, and this is a study that we just published recently in the Journal of Oral Maxillofacial Surgery, where essentially it incorporates our digital integration of our planned final prosthesis, working backwards to actually plan their zygomatic implants in a prosthetically favorable way. This lecture is not about zygomatic implants, however, just for your information, many times zygomatic implants can be placed in non-restorable positions or in simply prosthetically unfavorable positions. So what can we do? Well, we can plan our zygomatic implants in a restorative prosthesis in a restoratively favorable way, but how do we place them surgically so that they're going to be surgically predictable and have appropriate surgical outcomes? Well, we're going to plane the apex of our implant position in a restoratively driven way. We're going to plane the apex of these implants in the appropriate surgical position, and we complete our surgery. Now, this is beyond the scope of this lecture, but these zygomatic implants are placed in what's considered an extramaxillary or lateralized position, which is what allowed us to reduce the amount of buccal palatal cantilever. One of the pitfalls of placing zygomatic implants extramaxillary is that we have the possibility of running into soft tissue issues or periimplantitis. So to help prevent that, we need to thicken the tissue. And one way we can do that simultaneously is with buccal fat pad. So buccal fat pad can be used to thicken the tissues around these implants to help protect them and thicken the tissue so that they become surgically more predictable. So now we have a situation where we have favorable surgical outcomes, we have prosthetically favorable positions of the implants, and we were able to do this by working backwards and what we call the restoratively aimed zygomatic implant routine. Now, essentially, this allows for a predictable and satisfactory outcome. And this patient was able to be restored with 4 zygomatic implants with very little bone from the beginning, and was able to avoid any type of bone grafting and extensive amount of time. Now, we'll just have a brief discussion about smile line, and I would like to include this because when we talk about the idea of performing alveoloplasty, we have to have, and you'll hear Dr. Bedrosian say this all the time, but we have to have an appropriate indication to perform alveoloplasty, right? We don't want to remove bone unnecessarily. So in a patient who has a very high smile line, now, for example, in a dentulous patient who, when they smile, they show their alveolus. Well, number one, the indication for alveoloplasty is for enough restorative space. However, if you perform enough alveoloplasty for restorative space, but you're still showing residual alveolus on animation, then you run into the issue of potentially showing the transition line upon smiling or laughing. And in my opinion, that becomes an aesthetic failure. So in the situation where you have to perform alveoloplasty or alveolectomy for aesthetic purposes, it's very important to have a frank discussion with the patient that we are going to remove bone purely for aesthetic purposes, which brings up the question, do they need to have that performed? If they have that much bone, shouldn't we just be restoring to a teeth-only prosthesis, meaning an FP1? It may be more expensive, however, it becomes a bit of an ethical dilemma, and that's a big discussion amongst prosthodontists and surgeons as do we restore to the current level of bone with an FP1 prosthesis, or do we perform alveolectomy, remove the bone, and perform an FP3 prosthesis? And that's one of the, certainly one of the more debatable issues in our field. I just want to quickly touch on digital workflow, as this is not a digital workflow lecture, but it wouldn't be me if I wasn't mentioning digital workflow. And there are many applications out there that can help you attain that systemic approach to full arch implant rehabilitation. And part of that is incorporating photographs, intraoral scans, and various different diagnostic criteria to be able to perform digital wax-ups to not only demonstrate to the patient what the planned restoration is going to look like, but to be able to predictably be able to ascertain where your teeth are going to be in the final position. Now, this can be done for fixed restoration, such as veneers, but it's actually being done in full arch implant rehabilitation as well. Now, one of the difficult aspects of analog digital implant planning is ascertaining where the teeth are going to be with photographs, right? Where sometimes it may be difficult to have a patient smiling in a rebuilt denture. Well, what we can do is we can take a picture of the patient smiling and actually have a scan where we have a digital photograph and incorporate the digital wax up onto that photograph. So we can show the patient what their teeth may look like, and we can also know exactly where we're going to place that incisor position to then reverse engineer where our implants are going to be. Just some information for you, very nice articles that are being published right now about this topic. So in review, there's lots of information about this. Please think of every case as a case-by-case basis, but approach it from a prosthetically driven perspective. Think crown down. Once we know what our final prosthesis is going to be, we can then reverse engineer the rest of it. Okay. The way we do that is by knowing our diagnoses in and out. We need to be able to classify these patients. We need to be able to know what is going to be predictable in that particular situation. We have to have a basic understanding of biomechanics, reducing our amount of cantilever if possible to help prevent future complications, such as periimplantitis, prosthesis fracture, screw fracture, so we can treatment plan with predictability. So when we have all of that information, it makes our treatment plans that much more predictable. We're eliminating all of the guesswork that we have during surgery because we know exactly what we're doing and exactly how it's going to turn out. And of course, like I mentioned before, treat each case on a case-by-case basis. Okay. Now, I just want to thank you absolutely for your time. I hope this was informational. If you've already known a lot of these basic principles, hopefully it was a good review. And thank you, Dr. Onarobi, for this amazing webinar series that you have put together. I think it's a fantastic opportunity to be able to contribute globally to the dental community.
Thank you so much, Dr. Shouvik. That was very, very brilliant presentation. I'm just going to say out here, I need you to come back and do a 1 hour of this, a little more detail in. So we are planning to have a course, an online implant course, and this is going to be one of the foundational lectures. So hopefully once we have it, scheduled, we'll bring it back so we can have that, so that every student, every African dental student will have an opportunity of taking these lectures. I know you guys have some kind of lectures, but these are quite robust, and you will learn a lot, and hopefully we can have some laboratory components. Thank you so much. I'm going to run the poll again. Guys, we have a poll here, and Dr. Shouvik is going to go back, is going to come back and give us the answers to this question. So please, I'm going to relaunch this poll. All right, so we have 4 minutes. Please go through just from what we have heard. So just answer as much as you can, and he will go back and he'll give us the answers to the questions when we are done. So we have 4 minutes. I'm going to extend it to just 5 minutes. I want everybody to answer the question. Please just go ahead. Of course, you're having some technical difficulty, and those on Facebook, you won't be able to do this. But if you are on Zoom, I want you to answer the question. Anna, your name is not going to be attached to your answer, so don't worry about that. We are rounding up. Let's get it up to 50% at least. All right, I'm going to end the poll, and I'm going to share the results. So go ahead, Dr. Shouvik, could you please go through the questions? And
yeah, absolutely. So let's talk about number one. So which of the following classifications describe the pattern of alveolar ridge resorption in the aging patient? And the correct answer in this case is the Kaywood and Howell classification. So the Kaywood and Howell classification, just to quickly review, this is that classic paper from 1988 where they actually looked at the skulls to see how the bone is resorbing. And they determined that essentially the bone resorbed from a buccal direction, from the vertical and horizontal views. These other classifications are in there to kind of throw you off. These are other the Mish classification is a prosthodontic classification. Lefort has to do with a surgical classification, and the Siebert classification is looking at defects for bone grafting. Number two is called what's a composite defect, and this means that we are missing teeth, bone, and gum. So I think most of the attendees got that one correct, all of the above. Number three, we have the, according to the Bedrosian bone zones, a patient with adequate bone in the premaxilla, which is zone 1, but inadequate bone in the premolar and molar, meaning zones 2 and 3, has bones in which. So that means the patient has bone in zone 1 only. That's correct. The following are appropriate indications for alveolectomy. This is a very interesting question, Uvo. So high smile line, that's appropriate. Inadequate restorative space, that's appropriate. Finances, that's the hairy one. And surgeon convenience. So that is correct. Surgeon convenience is not an appropriate reason to perform alveolectomy. And number 5, when considering a full arch prosthesis, the following are indications to place an angled implant. So angled implants, they do maximize the AP spread. They do avoid vital structures. They allow you to place a longer implant so you have additional surface area. So the correct answer would be inadequate with a ridge, okay? Lastly, what is a possible complication of inappropriate planning in full arch rehabilitation? And this is the kind of theme of the lecture, which is treatment planning can help prevent many, many, many complications. And this is correct, meaning all of the above: fractured prostheses, fractured screws, peri-implantitis, and hopefully not paresthesia. Those are all possible complications of inappropriate surgical implant planning.
All right. Right. Thank you so much, Dr. Shouvik. This was really, really good. It's going to be available on YouTube later in the evening. If you go to the link, you can, share this with your friends and get your colleagues to, dental students. I need to see Nigerian dental students on this call. I know we have a lot of practitioners, many students from Ethiopia. I'm looking forward to seeing a lot more Nigerian dental students. Anyway, thank you so much, Dr. Shouvik. It's been a pleasure having you on Dental Webinar Series today.
Dr. Onarobi, thank you for having me.
All right. So we're going to move on. Tomorrow we're going to have Dr. Najla Kasabre and Dr. George Furat. It promises to be a very good one. Dr. Najla is a periodontist, and while Dr. George is a prosthodontist from the University of Michigan. Today we are going to move on to our next speaker, all the way from Minnesota. Dr. Aprit, are you there?
Yes. Good morning. How are you doing?
I'm good. Good to see you. Good to see you.
You too.
From the Twin Cities.
Yes, sir. That's right.
All right. It's a great privilege having you here today. Just gonna go straight, and if you need to add anything about your background, please go ahead and do.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator